we keep our guide. Thank you so much for joining today's session. As usual, I would request that we keep our gadgets mute so that during the sessions they don't disturb us. This is palliative care, didactic presentations and discussions. It is in this platform that as multidisciplinary team members, we share our experiences, we discuss certain concepts and topics and issues regarding palliative care is concerned. So it is hosted by us as Eswatini Hospice at home, but everybody is allowed to participate and contribute to the development of palliative care in the country, in the African region and in the world at large. We want to assure you that after the sessions, all of them, they are recorded and uploaded to the YouTube. I will share the YouTube channel during the session so you can check it after the session. I will share it, the name on chat. So you can then visit our YouTube and then try to follow some of the videos we have recorded in this session. We also encourage that, yes, we will share the channel as soon as we finish the session. Before we finish the session, I will upload the channel link so people can follow it. Where we are uploading the videos. Otherwise, my name is Sandile Mahlangu. So also in the YouTube channel, you will see a face similar to mine, and then you will know this is where you can access some of the previous videos. I think they date back to 2022. We have delved in a lot of aspects and dimensions of palliative care. And we are still hoping to continue with the support of our team, ECO India. We like also to apologize that in our last session, we couldn't finish or start well because of the internet. It downplayed us. But I've discussed with our social worker who will take us through the next remaining chapters for this year, that she incorporates the issue of communication into the presentations that she will have so we can get some part of it. But one thing I would like to emphasize to all of us is that for any palliative care to continue well or care of the patient with serious and life-threatening conditions, we need to build a strong backbone in our communication. In my experience is that most of the time we fail and build our patients around communication. So today we will be looking around on the topic on psychosocial support for the dying patient. And this is a very critical area, and I'm hoping after the presentation we'll have a moment to discuss. Today we apologize, we didn't have, we will not have the case, but in our next session, we will have much more discussion in one interesting case. I hope all of us will come and join so we will approach the finishing end with a style. So what I want to say is that most of the patients we are caring for, it's either they go for long-term survivorship and then finally some of them they passed on. And most of the time, the system is tailor-made for those people who are doing well and who can take care of themselves. And you find that most of these palliative care patients end up not getting the required support. So we are just adding on what we have been doing in the previous sessions on how to take care of those patients at end of life. So today we'll be looking at when a patient now is approaching the end of dying, how best can we support the patient, and especially and their loved ones, to see that they enjoy the process and we maintain comfort as much as possible as we can. Because even though we cannot reverse the situation, but we can affect the journey to make it smooth and make it lighter for the patients by providing psychosocial support. So without wasting of time, I will give this opportunity to Mercy to continue with your presentation, madam.
Thank you, Mr. Mashamo. Good afternoon, colleagues. My name is Mercy Shabangu, and I will be sharing today's presentation. I'm not sure if it's possible, Mr. Mashamo, that you kindly share the presentation for us. Thank you.
Hope now you can see it, madam.
Yes, Mr. Mashamo, please give me a few minutes. Thank you. Thank you, Mr. Mashamo. So today, colleagues, we are going to be looking at the psychological support to dying patients. We are basically going to be looking at what the needs are and how we can support those psychological needs of our patients, especially at end of life. So we are going to be looking at the key components of psychological support. We will also look at common psychological challenges at this stage. We will look at practical strategies that we can use. We will also look at the benefits of psychological support and professional support and therapies that we can use. Psychological support for the dying patient is a holistic approach that includes emotional support. It also includes therapy, spiritual care, and social connection. So this kind of support is all aimed at improving the patient's quality of life as they approach the end of life. Psychological support addresses the emotional, the social, and spiritual needs of both the patient and their family, including the caregivers. This fosters resilience, acceptance, and peace during a challenging time for the client and their family members. It can involve active listening and other specialized interventions like cognitive behavioral therapy and creating comfort through a supportive environment. Can we now move to the key components of psychological support? So we are going to look at these 5 components of psychological support. The first one is emotional support. It is important to provide a safe space for the patients to express their emotion. We can achieve this through empathetic listening and validation of feelings and reassurance. So when we provide emotional support, we should make sure that we do not make our clients feel inferior or feel discriminated or judged in any way, but we should ensure that we provide a safe space for them to express themselves. And these components, colleagues, we can also share them or empower the caregivers and family members on how they can also support the clients. So it applies to us healthcare workers and also those that provide care at home for our clients. The second component is specialized therapies. So for individuals needing more than basic support, there are therapies such as cognitive behavioral therapy that can help address distressing thought patterns. Another component that we can use is mindfulness and relaxation. Here, there is a use of techniques like relaxation exercises and mindfulness practices, which can help manage anxiety, because you find that for a number of our clients at this stage, there is so much anxiety. They experience a heightened sense of anxiety. So we can use those relaxation exercises and practice mindfulness with them to improve the present moment awareness and to alleviate any form of physical suffering. We can also provide spiritual support, which is also another component of psychological support. So with spiritual support, this involves assisting individuals in finding meaning in their experiences and providing spiritual guidance or support from religious leaders, or we can also use our chaplains. Hence, in palliative care, we always encourage that it is important to work as a multidisciplinary team, because we have different skills and we can be able to work together in assisting our clients. Then the last component is companionship and social connections. So when we provide this kind of support to the clients, we are aiming at fostering a supportive social network to help the patients feel understood and accepted, which reduces feelings of isolation and fear. So as we are providing psychological support to our clients, we don't want them to feel isolated or fearful or anxious in any way. Hence, it is important for us to promote companionship and social connections. This is where, even though the client is at end of life, we do encourage that family members should not keep the children away from their parents, so that they still maintain that type of connection with their loved ones or with their children. So it is important to maintain this one. Sometimes you find that the client now doesn't want to spend time with people, but it is important that in as much as we give them time alone, but we don't leave them by themselves for prolonged periods. So now we are going to look at the common psychological challenges at end of life. So we are going to look at the common challenges, the common psychological challenges. So as we know, our clients at the end of life face a range of emotional and mental health issues. These include fear, which can be identified through the client expressing that they have anxiety related to the unknown, or the client saying that they are experiencing some loss of control, or they're experiencing pain, or even the fear of leaving their loved ones behind. So those are the common challenges that we should be able to look out for and identify, because now if we are able to identify that this client has fear, we are able then to go back to how can we support the client, as we've mentioned, strategies of mindfulness and other strategies that we are still going to get into. Another common challenge is grief and sadness, where clients experience feelings of loss for the future. They experience loss of independence and loss of those cherished activities. So this is quite common, because now chances are the client is at ECOG 3, ECOG 4. They are more dependent on their loved ones for assistance, even in terms of ADLs. So now they are unable to do a lot of things for themselves. So this also poses as a challenge for our client. It's a psychological challenge that we should make note of. Then there is anger. This is where frustration and resentment over that terminal or life-threatening illness occurs. And sometimes the clients experience some kind of, or feelings of unfairness. So it is important to be able to identify now that this client has anger, so that when we work with them, we understand even the reasons why they express themselves in certain ways, the choices that they make in terms of their care or in terms of their medical treatment. So it is important to identify that the client it has anger. There is also depression at this stage of at this stage of the client's life, which is also a psychological challenge. So we can identify it through symptoms of persistent sadness, hopelessness, or loss of interest in activities, which is why then it is important to make a thorough assessment so that we can be able to rule out or identify that the client has depression. There is also social withdrawal, which also poses as a psychological challenge, where you find that the client experiences a sense of isolation, especially if visitors decrease because people are now uncomfortable or unsure of what to say, which is why earlier when we were talking about the psychological support, we mentioned that it is important that we maintain companionship and social connections for the client so that they do not feel like now they are left alone. And in this case, with social withdrawal, sometimes the family members or other loved ones now are afraid to come and visit the client because, as I've mentioned, they do not know what to say to the client anymore. So it is important then that we have family meetings with the family members and loved ones so that we can educate them about what is expected at each stage of the patient's life or trajectory of the disease, so that when these things happen, they do not get overwhelmed, but they are able to understand and know the role that they should play in supporting the client. Then the last challenge is anticipatory grief, which is the grieving that occurs before death oftentimes, and it can be experienced by both the patient and their family members. So it is important for us to be able to identify that if the client or the family member are experiencing anticipatory grief. So we're going to look at the practical strategies that we can use as healthcare workers, but we can also empower caregivers and families on how they could support their loved ones. So we can start by creating a comforting environment. So in a setting that maybe, let me say at home, this is where maybe the family members can use some kind of like soft lighting or play soothing music at a low volume to create a relaxing atmosphere for the patient. But in the facility, we can make sure that we find a place that is private, where there can be no disturbances or any background noises occurring, so the client is very comfortable. And as we have conversations, there are no distractions occurring. Another strategy that is important is being present. Here you get to spend time with the client and talk to them. Well, there are some clients who can no longer talk anymore. So for those clients that cannot be able to respond verbally, we can spend time with them, even when we are taking care of them, just letting them know that now we are doing this, now we are going to take a bath, now it's time for feeding. That is also being present for the client. Some clients, we know that maybe, I'll make an example with Christians. This client really enjoyed reading the Bible. So now it is the opportunity that we can read the Bible for that client, so that they can feel that we are there, we are supporting them, and we are uplifting them. Then another strategy that we can use is involving the patient. So in a situation where the client is still able to communicate, we can ask them what they need, and we can involve them in decisions about their care. In palliative care, we promote a client-centered approach where we say the client's autonomy is very important. So another way of supporting a client psychologically is involving them in their plan of care, which is why goals of care discussions are very important. Advanced care planning is very important. Those discussions are very important to have them with the client. And sometimes you find that maybe the client can no longer talk, but maybe they can still write. So we can still use that means of communication to involve the patient in their care. We can also offer physical comfort, like holding their hands or gently massaging them to provide comfort. But it is important to understand or to respect gender or culture, or should be gender and culture sensitive in such instances when it comes to physical comfort. But at a home setting where the client is with their loved ones, you find that it's not much of a problem, but in our facilities, we should really be mindful of how we go about this one. Another strategy we can use is to allow for alone time for the client. We do say that sometimes clients tend to withdraw, but it is important to reassure the dying person and their loved one that it is okay for the patient to spend some time alone. But as I mentioned before, it shouldn't be for prolonged periods. From time to time, family members, loved ones should check in on the client to see if they need anything and to just sit in with them at times. But also, it is important to just give them that space by themselves. Then it is also important to communicate openly and honestly. We have spoken about communication a lot of times in palliative care. It is a very key component that you cannot assess the client without really being thorough with it. So, as healthcare workers, we should communicate openly and honestly, and we should encourage family members and caregivers to also practice the same. We do understand, colleagues, that talking about death is often difficult for both the patient and their loved ones. But we should try and initiate an honest conversation that can be valuable. And as we are having these conversations, we should listen without judgment, and we should be able to respond to the client's feelings. But we should try and avoid being overly optimistic, because that might be misleading to the client. And as I've mentioned, the communication should be honest or should involve honesty. Another strategy that we can use is encouraging self-expression. This one is almost similar to the one of involving the patient. So here we help the patient to process difficult emotions by encouraging them to express their fears, their worries, their hopes in a very safe space. And we help them to name those emotions that they are experiencing. Then we help the clients with validating their emotions. It is important, colleagues, to acknowledge the patient's feelings of anger, feelings of fear or sadness, and grief as normal, and validate those and use validating responses to those situations. But as we normalize these emotions, we should avoid maybe trying to fix the client's emotional problems. Then it is also important to preserve dignity and control. Here we can offer choices and involve the patient in their care and decision making to help them maintain a sense of control. As we mentioned, when it comes to the psychological challenges, at times there is grief and sadness where clients now are starting to feel some type of loss of control on so many things. So here, by offering them the choices, they are able to maintain that sense of control. And these kinds of conversations could involve issues of discussing where they want to be cared for, who they want to take care of them during such a time. Then we can help the clients process unfinished business. This may involve maybe facilitating conversations with loved ones to resolve whatever conflicts that are there, where they are able to offer or receive forgiveness, where they are able to express love and gratitude amongst the client, family members, and the caregiver. Can we now move to the benefits of psychological support? Okay, we are going to look at these three benefits briefly. The first benefit of psychological support is that it improves the quality of life. So with psychological support, or if psychological support is present, this enhances the quality of life for the patient and their families by helping them navigate complex emotions. And this is seen to improve the client's quality of life. Then another benefit is that it offers or it fosters resilience and meaning. So with psychological support, individuals are assisted with developing coping strategies, building resilience, and finding meaning in the remaining time. And it also aids with better symptom management. Psychological principles can help ease physical suffering and improve a patient's ability to communicate their needs, hence the importance of psychological support. Can we move to the next slide? We are going to look at professional support and therapies that can be used as a means of providing psychological support to our clients. A team-based approach is often most effective for providing holistic support to patients at end of life. So this is the list. This is the list of professional support or therapies that can be used at this stage of the client's life or condition. We do have psychologists and counselors who provide specialized therapies to help patients process emotions and develop coping strategies. There are also social workers who guide patients and families through emotional and practical challenges, including accessing community resources and also facilitation of family meetings and family mediations. Then there are spiritual care specialists and chaplains who help patients explore spiritual questions and find meaning and purpose and comfort at this point of their life. Then there are also complementary therapists where you might find that relaxation techniques like music therapy, massage, or art therapy are offered to reduce anxiety and to promote emotional expression. Then there are bereavement specialists who provide ongoing grief counseling for family members and caregivers for an extended period after the patient's death. But as we mentioned, clients, grief counseling can start even earlier because loss occurs earlier, even before the client passes on. So, which is why we are always encouraging multidisciplinary team approach, because this is where we are able to now reach out to other colleagues and have those discussions and meetings on how we can best support the client, caregiver, and their family members. In conclusion, colleagues, it is important to collaborate with mental health professionals, social workers, and chaplains to ensure that there is comprehensive care for our clients. And with psychological support, it extends to the family. It offers them education on caregiving, stress, self-care strategies, and support during their grieving process. Thank you.
Thank you, Mercy. That was Mercy presenting on how best to provide psychosocial support. Thank you so much, Madam. For those who may need this presentation, we have uploaded it into our platform. So just in case I forget to mention that when we're approaching the end of our So this presentation has been uploaded already to our platform. To summarize maybe to what I've picked from this, there's a lot she has shared to remind us on this journey. You know, as she's presenting, I'm just thinking, you know, looking after people with terminal or life-threatening conditions is not an easy task. It requires a lot of understanding and a lot of support. And we thank Cecilia Saudos for such a thought and such a lifetime innovation to then boost the healthcare system with this palliative care. So what I want to say is that thank you so much, Mercy. But there are things I like us to understand that most of the time when patients are approaching end of life, most of the therapeutic interventions, they are not that much feasible. And most of the time we are going for more of psychosocial support, which involves psychological, social, and spiritual support. And it's more of in terms of dealing with the issues of ensuring the patient is comfortable as possible as you can, not excluding the symptom control, but the most investment goes towards stabilizing the patient in terms of psychological, spiritual, and social being. So it's very important that we understand that all the pillars, we need to apply them very well. I think it's in this module that we have also mentioned the issue of understanding palliative care phases, understanding palliative, the disease trajectories that patients follows, and then combining the palliative care phase, the disease trajectory, and the functional grading tools to predict the patient's journey so we can be proactive enough to help the patient and the families cope better. So I think if you want to need more of on these tools, you may visit the YouTube. I will share the channel very soon. My challenge is that when I go to YouTube, I might lose this. But what I'm trying to say is it's very important that we combine these things. So we are not caught on surprise together with the families. When the patient's families are surprised, and us also as clinicians, we are surprised. So we need to be more proactive. So we have these tools, the functionality status at hospice, they use the eco functionality status assessment tool. I don't know others, they use Kinowski. It depends on what facility they are using. And then we also have the palliative care phase that help us to see how the patient is moving. Sometimes the patient will move from unstable to stable, sometimes from stable status to straight to deterioration, or from deterioration straight to terminal phase. You know, they move up and down from the journey. Sometimes the functionality status, they will change depending on different factors that need to be examined and then be addressed. And we bring the principles of treatment that says we reverse the reversible. But what Mercy said is that one of the things I learned about the intervention that we need to put in place here, it's making sure that we are putting the patient at the center of whatever that is being done, and ensure she or he is involved at all costs. Since mentioned an issue of that, even if he cannot speak because they are now approaching the end, just the issue of reporting, this is what we are going to do. And what we normally see in our context is that the patients, once they are unable to speak for themselves, they tend to be guinea pigs. Sometimes they are not told, they are moved to places they never said they will. My experience with the patients, for those who have passed after I've met them and discussed, most of the time they die where they wanted to. families try all by means to respect, but those that have failed to do that, so you will hear that he died by the road. So those things are so bad. And I've experienced with patients who have been equipped with understanding the end of life, and then the family is provided with the most best psychological support to assimilate the reality and then support the family. You find that they, even though they die, but there's peace after them. So it's very important that we embrace this. Traditionally, we fight that, religiously, when we have a patient who's going to die, even though we preach heaven sometimes in other religions, but once one is going to heaven, we pray that he mustn't go sometimes. So you find that even it's hard for religious members or spiritual team members to tell the truth, that what they are seeing, and maybe patients that are anguishing in pain and anguishing in the pain that they want to confess some sins, maybe they want to mend some relationships, sometimes they want to make some certain confessions on certain issues. They are issues they want to put in place, Maybe they want to take their last Holy Communion. There are many things patients may want to do. So by being there, and this is the space whereby difficult questions are being asked. So, but maybe before I have my difficult question too, may I open the room for anyone who may want to share or add? You can share with your experience on how has been your experience with patients who are dying. What have you noticed? What do we need to note as palliative care providers that can help us improve? What can you share? What can you share? I would like to hear from you guys. Thank you so much, Zinhle and Askis, for coming late. But I hope you will cope and pick up a few pieces. Yes, team. Anyone who wants to share something? Have you met these patients who are at end of life, approaching death and dying? What else can you say we need to also know as team members? Yes, Maggie Gamete.
Thank you, Mercy. Thank you, Sandile. Thank you, Tim. Good afternoon. Okay, my sharing is just one aspect that I experienced, and I think I continue to experience with people who are dying. It's not, I don't know what to call it, but I would call it a ministry of presence. Where you are there with the patient or with the person, not talking, not praying, just being there. Because the patient or this person sometimes would say, just be here with me, and not say anything else or ask for anything else. So your presence is a ministry on its own to somebody who is at end of life. Because we don't know what they see, we don't know how they are feeling, but sometimes they just need someone to be with them before they depart from this world. So that's another thing that we need to consider. Frightening as it is for you as the person who is just present and not saying anything, or maybe who will see this person gasping her or his last breath, but be there because this person needs you there next to him or next to her. Thank you.
Thank you, Margaret. Yeah. I usually say that there are few tornadoes people go through, and as clinicians, we need to be prepared for. Sometimes when there's an emergency, when something critical has happened, then there's tornado of emotions. And another experience, you find that also by this time, even the caregivers are in the tornado, when there's a storm. They don't know what to do. Even if you can say they must administer gasoline, they even give, because it's the tornado they are in. But one of the advice you can give, you don't need to try everything that your hands can touch. Just be there. just been there. So yeah, it has what we call presence, even presence without silence, with silence, saying nothing, just be there. And the patient will really appreciate. Thank you so much, Margaret. Yeah. Anyone else who can share, team, what has been your observation, experience with people who have been in palliative care now for some time? They've seen things pass and go. What can you share with us? Yeah. Can you share? Yeah, boom. I'm looking for people who can shoot and then just share. I'm still looking for the link, but I got the doctor now. He's gone. I'm not sure how we will get the channel. Yeah, boom. Anyone else? So I wanted to ask a question. That have any one of us been asked? Has anyone been asked to respond to a difficult question asked by any client? For example, a family member or a patient asking you if he will recover, even if you see and clearly the diagnosis is clear, he is going to die, and he's stage 4, ECOG 4, palliative care, terminal phase. All indicators telling you. Have you ever been asked that? How do you respond? Is it easy? How do you call? I think we can share, especially my team from hospice can share. And Zinhle, I know you might have seen that at RFM too, whereby then the families are not yet accepting it. And they even ask you, how have you taken such difficult question, or any difficult question you have ever faced, and how have you approached it? Anyone? Have you made such? Hello. Oh, by the way, I'm with a social worker here. Let me show you. I forgot to report that I'm not alone. Today I have a friend. Normally I'm alone in this room, but today I have someone with me. So, Yebo, I have someone with me. Let me show you. We are. You see, we are a team here. Yes. So, guys, anyone with something to share? Yeah, that's a really difficult question, right? But I want us to share, guys, it's very tough. It's very tough. Let me share one situation. I had once have this situation, but it wasn't yet a question. The client signaled that he's now tired, he wants to rest, and he can tell her time has come. Unfortunately, when you are saying that, then the husband comes into the room. And I asked the woman, should I share the issue? He said, yeah, you can tell him. When I introduced the matter to the husband, he told me straight to the eyes, he's a Christian, he believes in God, no one is going to die. And then what I did, I had to say what he's saying is true, but we need to expect anything from now on, and then leave everything in the hands of God. And should it happen that she's dying, when ABCD symptoms present, please remember her wishes she used to share with you. And this man never listened to anything. I even showed them the end of life symptoms, and he was not that much interested. And I could tell this woman will not last long. I think after 2 weeks, going through this tornado of end of life symptoms, the woman died in hospital. And the person who called me was the husband. And he said, you know, when you were telling me, it made no sense. But when it was happening, I appreciated. So what I'm trying to say, to share with this case, is that I learned that, you know, sometimes education, we sometimes exclude the phase of educating the family. It was late time for me to do it, but I tried to share it politely. But educating the family members, it prepares them psychologically, because when it happens now that they were approaching the death phase, the patient was already dying now, they were able to handle and cope with the painful and hard symptoms that were presenting. So that's what I learned, that sometimes it's hard, but we need to continue to share with them, but in a polite way, and embracing. Mercy said that we need to acknowledge the emotions of the patients, even the emotions of the family members. Sometimes you will tell them, they will cry. But crying is okay. You give them tissue, you give them water, you allow them to cool down. And then you ask them the question, should we further discuss? Do they have any concerns? Because really it helps them. And they feel so ashamed when they understand that their relatives will wanted to die in the house, but they have already finally died the road. So sometimes telling the truth and politely educating them. But what I learned on that day is every time I consult the patient on initial visit, and I see that this patient is trajectorying towards end and in a faster rate, I introduce end of life issues as early as I can. And I've noticed that sometimes I don't become famous, and I become sometimes not the loved one in the family, because I will initiate it as a service we do provide, and initiative in the symptoms that usually comes with it. Sometimes I don't get the opportunity to have a second visit, and that patient, they will have died. And the response I get from the family member, they say, thank you for telling us the truth. It made no sense the time we saw you, but when it happens, it made ourselves ready, and it's like we were prepared to face the situations. So as healthcare workers, this is the most space we normally get engulfed by the grief ourselves, get engulfed by the emotions ourselves, and then the flight response takes on, and then we find all things we can do to run away. But that's what my experience as far as this is concerned. We need to, it's better when they've asked you, and there's a model you can use, Zinhle, when a patient can ask you, Eswatini, is our mother going to be okay? Or is it going to recover and be okay and go back to work again? Yeah, I have clients that have died still saying they want to go back to work. And when they ask you that question, sometimes it's better to not respond directly, because patients know the answers. Remember, when we are providing psychological care, you need to tell the truth and address the concerns as they are. But it's not wise to always share knowledge, but it's good to know how much they know. There's what we call Spike's model in palliative care. We have once presented it in our session, I think in 2022 or 2023. I don't know when, but it's there in our YouTube channel. I wanted to look for the name of the channel. Please Google it. I don't know how to take a link. On a serious note, I don't know. So let me do this. Go look for this. Oh no! Oh, drama. Yeah, I have a challenge. But go look for this name in YouTube. You will find all the videos here. If you look my son name and there's 3 letters, Mahlangu MNS, you will find all the videos. We upload them. Even this one will upload it there. So I've learned that these models, like the Spikes model, the Ask, Tell, and Ask model, helps us a lot in providing psychological care, even in this point in time. So, yeah. Anyone else who might want to share? Yeah, Bo. Do you want to say something? No. Okay. Anyone, team, anything to add, Mercy? We were just sharing what we've seen with this, how easy it is, dealing with patients approaching the end. How easy it is. Is it easier to stay there and be present? How has the family say? Have they been able to handle it? What have they been sharing? It can help us all. I don't know. Ndobeko, in your time in this spectrum, have you ever had an experience to deal with a patient who is approaching the end and they need to provide psychosocial, psychological care at that point? I'm just taking few members. Okay, Ndobeko has nothing to share. Mr. Mhlandi, you've been in the field for some time now. I think you can share something. Anything you may want to add to say? Mr. Sabelo, is there anything you may like to share? Now we are closing as I'm looking for our next, maybe possible last session for the year. Yes, Magaji.
Yeah, but thank you, Mr. Mahlangu. Thank you, Tim. Something else has come up in Gondwanyami as we've been talking and talking. The other very challenging question that you receive, maybe now from the caregiver or from a family member, would be let me say this one from exactly what the caregiver said. My father has difficulty breathing. They had an oxygen concentrate at home, but the time when this person called, they felt like it was not helping him to breathe. So he asked me, can I take him to hospital? I said, what has been his will about going to hospital when it comes to this stage? And this caregiver said, he said he doesn't want to go to hospital, and even now he doesn't want to go to hospital. So I said, I'm very sorry, but can you abide by his wish?
Yeah.
Okay, this man said, okay, Maggie, I'll do that. I said, okay, I know it is difficult. It's very traumatic for you, but please give him his last wish, being at home. And they did that. Guess what? After his father died, he exactly said, thank you, Maggie, for encouraging me. It was very difficult for me to see my father dying. But the fact that I honored his last wish, I am at peace. Thank you.
Yeah. Those are the experiences, guys, we are trying to say. Share. What has been your experience with this? It's not an easy thing to provide psychological at this point in time. For us as clinicians, we are socially, culturally, religious people too. Even if you have a degree in whatever or what certificate you have from school, But sometimes, you know, even if you know this is the truth needs to be done, it comes sometimes, but. And the family members are putting the pressure to, they are giving even the whole rationales to say, oh, no, we will take you to so and so, so and so. You know, yeah.
Excellent.
Yeah.
Maybe for me, I can say it's not an easy job. It's not an easy job at all. Getting to the patient's house or place and seeing that the patient is just a few months or weeks through to dying, and you hear the children or the family members after the assessment is done, they come outside with you and be like, is Mkulu is going to be okay? And you are really tongue-tied because it's not easy telling somebody that no, your mother or your grandfather is going to die. So I just think it really needs so much strength, and I don't know, but it's just not an easy job.
Yeah, thank you, good. It's not an easy thing, Tim. I wanted us to share. I don't know if others are able. Is anyone we are not leaving behind to share your own experience? It has been nice to help them. Sometimes they don't understand. They don't. There are many have said, oh, he's not eating. Okay, as kids, don't give him the food. And I'm not a famous man. We are saying, let's not give. And then I will explain, maybe at this point in time, if he's closing his mouth and is not taking anything, allow him not to take it. Maybe it's not going to be beneficial at this point in time. And it makes no sense to a Swazi or an African person, because we believe food will keep him or her alive. And then when he has died, you know what? He died at night. That's the error. I understand. No, understand. No. If I didn't get your advice, we would have done ABCD. Thank you. So this is what already you are saying. So the patient, they speak, but the culture we are going through. So sometimes discussing ahead with the families, they will say to you, he has been or she is saying this now and again and again and again. And then that's how we are relieving them. Whenever they are dying, maybe you are no longer there, they are able to cope and handle the situation. So thank you so much. I wanted us to share these experiences so it can strengthen one another, because we need to do this so that we encourage our patients not to be neglected when they are approaching the end, even if you are not going to be there when the process is happening, that they are dying actively, but at least we have equipped them with all information that they need. So let's go back to education, and sharing the benefits of understanding patient's autonomy and bringing value to the patient other than ours. So we will have our last but not least session on the 5th of November, whereby we are going to look at, now that the patient is gone, how then do we continue with the bereavement, and then understand the concept of bereavement, and how do we go about providing it and its value on these patients and family members. So we are going to look at it. Mercy today introduced one of the aspects that will be covered in that topic, which is grief. And he mentioned different types of grief that kicks in here. So as we are providing the psychological package, but we're going to break it a little bit down to then bereavement, to see then now how then do we help patients to cope with different scenarios of loss. Actually, it's not that, because we'll start after the client's death, but we started from diagnosis, but we will, the social worker will unpack in depth in the future. And I'm looking forward to have a case in our next session. So thank you so much for joining us today. If you want to look for all the videos we have had in palliative care, you'll go for Mahlamo MNS in YouTube. Then you will find all those videos we have used and recorded before. Thank you so much for joining. I think next year, we are still preparing for next year. Next year will be palliative care, but centered around the care provider, which will be us. We'll be equipping ourselves and how to cope, how to do it for ourselves so we can remain stronger. And I think that will be the end of today, unless I'm missing something. Presentation is uploaded. Session will be uploaded in YouTube after 30 minutes from now. Have a nice day, colleagues. Thank you.